Hi, everybody. My name is Anna Shah. I'm one of the assistant professors of neurology here at the Rocky Mountain MS Center at the University of Colorado. And today we're going to talk a little bit about multiple sclerosis for the primary care doctor. So let's get right into it. So what is multiple sclerosis? And I think understanding this is one of the most important pieces about understanding how our patients are affected and what this disease means for them. So MS is a chronic inflammatory disease affecting the central nervous system. Just a quick reminder for those who neurology seems like a lifetime ago. Central nervous system is just the brain and spine, so no involvement of peripheral nerves or nerve roots or plexi. And in multiple sclerosis, we see both neuroinflammation and neurodegeneration simultaneously. Neuroinflammation tends to be most predominant early on in the course of disease, with neurodegeneration being more predominant at the end of disease. Now, the image that you see on the right side of your screen will show us the difference between a normal neuron and a demyelinated neuron. And so when you see a normal neuron, you'll see the cell body, which is that starburst-looking shape that's in yellow. You'll see the axon and then the dendrites at the end. The little orange rectangles represent areas of myelin. And of course, signals are strong through a normally functioning neuron. Now, when you have a demyelinated neuron, meaning a neuron where the myelin has been affected, such as MS, you can kind of see these bite-sized pieces taken out of the myelin. And you can also see that sometimes when there is damage done to the outer myelin, you'll also see damage done to the inner axons as well. This results in a slowing of a signal passing through or the absence of the signal altogether. MS is an immune-mediated disease, like we already mentioned, where the inflammation is affecting myelin and the underlying nerve fibers, or those axons. And again, only affects the central nervous system, and the damage can really cause a variety of symptoms. And this is one of the things that makes MS so complicated, is that we run into issues with diagnosis, because sometimes the symptoms are so varied. It can be attributed to a variety of things, and it makes it hard to tie them all together. And then we also will focus in on symptom management as well. Going left to right, kind of looking at these different icons, we'll go through some of the symptoms that MS can cause. When we think about vision, we think about double vision, loss of vision in an eye, which we've commonly referred to as optic neuritis. The safety pin in the second icon represents paresthesias, or pins and needles. There are other sensory disturbances our patients can have, which also includes numbness, sometimes shooting type pains or vibrating pains. This icon right here represents ambulation difficulties. So a lot of our patients, particularly before the highly effective immunotherapy, which we'll talk about in just a moment, needed help walking. So things like canes or hiking poles, walkers, wheelchairs. Fatigue is one of the most common symptoms that we see in our MS patients, with about 85% reporting fatigue. Weakness, again, another common symptom. Bowel bladder difficulties, and this can be retention or incontinence of either one of those two systems. Dizziness or vertigo. This icon right here represents spasticity, which is muscle tightness, sometimes muscle spasms. Mood disorders are quite common in MS. So think about anxiety, depression, cognitive issues, and heat sensitivity. Now, the etiology of MS is not necessarily as simple as if you have this, then you're going to get MS. So the etiology of this is quite multifactorial without one clear cause, and there is not a cure. But absence of a cure does not mean we do not have treatment, and does not mean we do not have really good treatment. So we'll get into this in a moment, but highly effective disease-modifying therapy, or DMTs as we refer to them, are one of the best treatment options that we have for our patients with MS. And we'll go into why early treatment is the best type of treatment. So let's look at how common is this. So often, average age of onset is between 20 to 45, with about 80 to 85% of our patients presenting in this age range. Now, that is not to say you cannot present outside of this age range. I think the oldest patient I have diagnosed with multiple sclerosis was in their 70s. So while uncommon, still entirely possible. Females predominate those that get MS by a 2 to 3 multiplication factor. And it is historically thought that regions furthest away from equator were most likely to be affected by this. So this part about race and ethnicity is one of the most interesting things, I think, when thinking about the epidemiology of MS. MS was previously thought to be primarily a disease of Caucasians, but there have been newer studies published in the last couple of years, primarily through the Kaiser database over in California, that actually show that the incidence and the prevalence of MS in their African American or Black American populations were higher than their Caucasian counterparts. Now, this becomes important because we think about how does that play a role with disease severity and disability. Now, this is an area where we still need more studies, but it is important for all doctors, especially primary care doctors that are seeing this at the forefront, to make sure that they are aware of this information, because we know those that are Black Americans or those of Hispanic ethnicity are more likely to have more rapid disability accumulation and more severe disease. What is the prevalence of MS? Now you can see the image there on the right that shows slightly different prevalences in different regions. Here in Colorado, we're thought actually to have one of the highest incidences of MS, and the reason for that is not quite clear. However, in the United States, the National MS Society did some prevalence estimates, and you can see from 2010, where there were about 730,000 cases estimated, it jumped almost 200,000 when that re-estimate was done in 2017. Now, there's likely a variety of factors at play here, including improvement of our diagnostic criteria to really catch individuals earlier on in their course of their MS. Another one is probably that MRIs are a little bit more accessible and we're able to image easier without quite so much insurance pushback. And then there might be other factors at play, maybe diet, environment, other things that we'll discuss in just a moment. Worldwide, it is estimated that we have about 2.8 million patients with MS. So this is certainly not an uncommon disease, nor one that I would expect primary care doctors not to see. This becomes incredibly important, and when we're thinking about the impacts of MS for our patient population. Misdiagnosis before the actual MS diagnosis is quite common. Some studies report up to a third of patients are being misdiagnosed before they officially get diagnosed with MS. Most common misdiagnoses include things like anxiety, or functional neurologic disorders or psychogenic disorders. This tends to be more prevalent in women and individuals of color. In different quality of life surveys that have been done that have looked at several thousand patients, I thought this was particularly important when they say well over half of patients are reporting limitations in their daily activities related to symptoms that they have gotten as a result of their MS. So while MS can be a very visible disease, particularly with thinking about things like weakness or ambulatory difficulties, there are quite a few invisible symptoms in MS that are always important to think about, like cognitive symptoms, fatigue, and pain. There's a higher rate of broken relationships in MS, and there is a hindrance of ability of those that have MS to both progress in their career and keep their jobs. We know that the implications are worse as people age, including higher rates of unemployment, lower incomes, less social support, and then eventually needing more help with activities of daily living. This also is very important when we think about what are the costs associated with MS. And of course, this is important for our patients and important for us to know. On the other side of the coin is their healthcare providers. So disease-modifying therapies cost way more than they should. So when we look at the cost of medications going from 2011 to 2017, the costs have doubled. And some of them have increased up to 60% just in the last 5 years alone. When we look at average costs of disease-modifying therapies, the last estimate I have is from 2 years ago, which was almost $92,000 a year. And you can imagine that this number is only continuing to increase at astronomical rates. We know the average healthcare costs, both indirect and direct costs, are estimated around $69,000. Now, this estimate, again, is from a few years ago. I would not be astonished if these numbers were continuing to climb. And in about 1/3 of cases, MS patients paid 100% of the cost for their ambulatory aids. And so again, just things for us on the healthcare provider side to always keep in mind. Now let's take a quick look at what does MS do? What is the natural history of MS? Now we have a lot of data available about this because we did not have treatments for quite a period of time in MS. So when we think about MS, we often hear about clinical relapses. Now, relapses are new neurologic symptoms that last over 24 hours. And when we think about clinical relapses, we think about them occurring more often early on in disease course, so the left side of the x-axis. And then when we think about MRI activity, one of the really interesting pieces with MS is somewhere between 90 to 95% of brain or inflammatory activity in the brain can be clinically silent, meaning we often see patients with MS that have 10 to 20 times higher the number of MRI lesions than they have had clinical relapses. And if we look at kind of what happens over time, we originally on our first slide talked about MS being a disease of both neuroinflammation and neurodegeneration. That neuroinflammation really decreases as time goes on, but we see this steady increase of neurodegeneration, which can show up as accumulated disease lesions and a decrease in brain volume. And this becomes important because this is really what's contributing to the disability in our patients. Now we'll take a step over to the diagnosis side. Now we won't go through this in immense detail, but I think a little bit of a bird's eye view of this is important. There are two different criteria that we think about when we're thinking about official diagnosis of MS. One is dissemination in space, and the other is dissemination in time. So let's go through dissemination in space first. What dissemination in space means is there's 4 identified locations within the brain and spinal cord where MS lesions typically occur. And you can see them listed here. 3, the first 3 listed are in the brain. And of course, the last one is in the spinal cord. So I'm going to show you an example of an image that we might see with someone with MS. Now, this is probably someone with more severe MS than we see on original diagnosis. What we're looking at is this is an axial cut of a brain MRI, and we're looking at a T2 flare sequence. Now, a T2 flare sequence is really what highlights these lesions better than any of the other sequences do. And what we're looking for is lesions that are greater than 3 millimeters. And we're often looking, particularly when we're looking in the supratentorial area, we're looking for lesions that are periventricular or juxtacortical, and you can see those delineated here. These T2 flare lesions can happen from the actual scarring from MS, they can happen from inflammation, or they can happen from the demyelination itself. Now, there is not any correlation between how many of these lesions someone has and their disability status. So when we think about common questions that patients ask us as neurologists and probably ask their primary care providers as well is, how many lesions do I have? Does having more lesions mean that I'm going to do worse? And the answer to that is not really. If you imagine areas of the brain, there are certainly areas that are more high real estate, thinking about areas in the brainstem or spinal cord, as opposed to some in the subcortical white matter. So the T2 lesions, it doesn't necessarily matter as much how many you have, but what's more important is where they are. That's really what contributes to disability. We also look at a sequence often called the T1 sequences. Now, what the T1 sequences show us is where there is axonal damage. And this is something that we can use better as a predictor of future disability by looking at the amount of black holes, which does not have the best name, but looking at these T1 hypointensities or black holes as a correlation to disability. This is a gross anatomic specimen of a brain of someone with MS. And what you can imagine is, just as a recap, all of this central subcortical matter is all white matter. And you've got your cortex around the edges, ribboning around the brain, and that's your gray matter. So right here, what you're seeing outlined in that red rectangle is an area of demyelination, which makes sense because you can imagine if you're taking the myelin away from white matter, it's gonna look gray, because the difference between gray and white matter is myelinated and gray is not. So let's go back to our criteria for diagnosis of MS. So we talked about dissemination in space and having lesions that look typical for MS, so certain sizes, certain shapes, in those 4 locations, and having them at least in 2 out of the 4. The second combination, or second contribution to our criteria, is dissemination in time. Now, there's multiple different ways to kind of fulfill this criteria. You can either have 2 clinical attacks that sound consistent with a demyelinating pathology, so something like optic neuritis, or I have a buzzing down my spine or into my arms every time I flex my neck forward. You can also have simultaneous enhancing and non-enhancing lesions demonstrating a dissemination in time. Or the newest addition to the criteria as of 2017 was the use of lumbar punctures and looking for CSF-specific oligoclonal bands. Now, I will throw out these caveats because I think these are very, very important. Not all white matter lesions are necessarily related to MS. It must look typical for a demyelinating syndrome. And this becomes important because we know there's a whole gamut of pathologies that can cause white matter hyperintensities or white matter lesions in the brain, including high blood pressure, high cholesterol, diabetes, tobacco use, migraines is another common cause. And so we want to make sure that if we're seeing someone with white spots on their brain, that it looks in a classic characteristic pattern for MS. Lesions must also be present for a diagnosis of MS. So if you're suspecting MS in somebody, a brain MRI or a spine MRI are done and there is no lesions on there, then they cannot by definition have MS. I think I hit on that last point already, but clinical attacks must be typical for those experiencing demyelinating disease. So what are the types of MS? And these become a little bit more semantic. And I think this will probably be something that will phase out in terms of clinical practice use, probably over the next decade. But the most common type of MS, meaning over 80% to 85% of individuals when they're first diagnosed with MS are diagnosed with this type, which is relapsing remitting. What you can see is an illustration where the x-axis is time and the y-axis is disability. Patients have some sort of neurologic symptom that's representative of new inflammation, and you get an accumulation of disability at the peak of that inflammation, and then the symptoms remit to some degree. And then patients are often left with whatever portion of their neurologic symptoms didn't fully remit. So you kind of almost see the stepwise pattern. Now, on the other hand, primary progressive MS is the slow accumulated progression of neurologic disability, where patients might say, gosh, I can't remember the difference day to day, but comparing myself to 5 years ago, I know I feel worse, or I know I gradually needed to start using a cane maybe 5 years ago and then a walker a year ago. Now, secondary progressive is a combination of the two, where an individual starts off by having these relapses with some sort of partial to complete remission, and then at some point in time, they transition into this progressive component. And then there's relapsing progressive MS. And now one of the things that's important, and one of the things I like to emphasize with my patients that are sometimes hesitant about starting treatments for MS is we know a lot about what happens if we don't treat. So before we had good, effective disease modifying therapies, about 50% of people in this category, the relapsing remitting, turned into this secondary progressive MS within 10 years. And about 90% transitioned to secondary progressive MS within 25 years. And this becomes critical because while we have good treatments for relapsing remitting MS, we do not have good treatments for secondary progressive MS. So what causes MS? Like I said at the beginning, it's a whole host of a variety of factors. There's infectious environmental factors, non-infectious environmental factors, and then of course, genetics that somehow creates the perfect storm for the development of MS. So let's look at genetics really briefly. Now, MS is not a typical hereditary disease where we say, gosh, if mom or dad has this, the child will get it. We know that when we're looking at identical twin risks, in terms of if one has MS, what's the chance of the other getting MS? The risk is really only between 25 to 30%, which you're saying these are two individuals with identical genetics, and then also individuals that theoretically have grown up in the same environment. So it's really interesting that the rates are that low. I typically counsel most of my patients, if a parent has MS, the risk of first-degree relatives acquiring MS is somewhere between 2 to 4%, with female first-degree relatives being at a slightly higher risk than male first-degree relatives. There was a big study done, a big genome-wide association study done evaluating multiple sclerosis back in 2019, where they really identified over 200 different MS risk single nucleotide polymorphisms. And these were really identified in a variety of immune-related cells. One of the things that I think is really fascinating is that one of those SNPs was identified on the X chromosome, which makes us wonder if that has some role to play and why females might be more predisposed to multiple sclerosis as opposed to their male counterparts. Nonetheless, all of these variants that have been found are not necessarily equal. We know that about 10 to 11% of the contribution from a genetic standpoint really stems down to this genetic risk factor, which is HLA-DRB1, 1501, or 1503. Now, the Epstein-Barr virus has gotten a lot of traction in the media as of late in terms of its role in the cause of MS. Now, we know the risk of someone having MS if they are EBV IgG negative is quite low. The risk of developing MS if an individual had mono in adolescence or adulthood is about 2 times higher than their counterparts that have not had that. But it is interesting that those that have infectious mono versus are EBV negative, we know have a much higher risk of having MS. Now, some people have argued, is this the direct cause of MS? And I don't think that's necessarily the case, because there's a lot of people that get EBV infections that don't go on to develop MS. So an interesting theory is it EBV exposure in those that already have a genetic predisposition? When we think about geographic variations, there are a variety of different locations that are thought to be higher risk compared to others that are lower risk, as illustrated here. And part of that probably stems from vitamin D exposure. So the most common thing I will counsel my patients that already have MS, if they're worried about first-degree relative risk of developing MS, is to make sure their vitamin D levels are adequate. We know this is a huge risk factor in the development of MS. Adolescent obesity has also been associated with a higher risk of the development of MS, and then tobacco exposure actually has a 6 to 10-fold increase in the risk of developing MS, particularly during adolescence. So these are characterized as modifiable risk factors that patients can be counseled about.